So my name is Georgia Lee. Now, I wasn't meant to chair this session. I was definitely going to come along to it, but I'm just standing in at the last moment, and I'm absolutely delighted to find out more about it. And I hope you have 101 questions. So what I'm going to say before we start is, if you can, there's going to be no questions in the audience. So if you can use the Slido. I've never used this before, so I'm learning by doing, but so any questions at the end. Okay, so the session today is Medicines Management by Choice, Not Rota, and I'm absolutely delighted to introduce Isa Dasu-Patel, who is the CEO and co-founder at Connect Care, and Dee Wallace, who is the head the Health and Care Innovation Leader, Oxfordshire County Council. Now, Sally was meant to be joining us, but we're having trouble locating her. We think there might be some kind of issue with the hospital. So anyway, but we've got lots and lots of things to talk about. Okay, so just to sort of set the scene. For too long, we have lived in a world where health and care is done to us rather than with us. And I think the theme of this conference so far today is very much about how we as people can be involved in the process. Thank goodness it is finally changing, and we are catching up with people's expectation. Despite medicines being the most common intervention in healthcare, they have lagged behind in the transformation at the cost of people's independence. And today's session is going to explore a very exciting and high-profile project which has been carried out in Oxfordshire, and it's bringing a number of different sort of disciplines together. It's bringing health, social care, and pharmacy to really radically rethink the medication support pathways, and it's helping people in the community as they age. And importantly, is focusing on positivity, activity, and keeping people independent, and crucially, treating them with dignity. And I think this is such a wonderful word to be able to think about. So I'm going to introduce Isa. You're going to sort of just set the scene for us, aren't you? So now you've carried out some really interesting advisory roles within the NHS, and I'm really keen for you to let the people here know a little bit more about what you're doing. So if you can do that, and then I want to find out from your work that you've done in the past, what was it that triggered you to think about this project that you're creating about rethinking the medicine pathway? So over to you, my darling.
Thank you. Is this working?
Yeah.
Perfect. Great stuff. Well, thank you everyone for joining us today, and thank you, George, for chairing as well. I know it's short notice for you to come in. Sadly, Sally, Sally is the Home First System lead, so looks at the kind of out of hospital discharge pathways at Oxford University Hospital. Sadly, I think because of some last minute emergency, she's not able to join us, but Dee and I will more than happily cover off everything. So as you mentioned, George, I was previously an advisor to the NHS during the pandemic, and as I'm sure for everyone that's interested in this topic, and probably why you're here, the pandemic spurred a whole kind of revolution in the way in which we think about health and care. And at the time, the NHS made a very heavy investment into what's called remote monitoring or virtual wards. And fundamentally, that's about providing care to people in their own homes. Because historically, we've always, and as you touched on, healthcare was done to us. We'd go to an institution, we'd go to a hospital, we'd go to a GP, we'd go to a care home. And that was the way in which we know and receive care. But now it's all about, well, how can we provide care to people in their own homes? Because fundamentally, we all want to live independently, and we all want to receive care in the safety and comfort of our own homes, rather than being in an institutional facility where often you have to wait hours just to even get an appointment or see a human being. And so during that time, a lot of investment was made into what's called COVID oximetry at home. So the UK was very proudly, actually England at the time, was the world's first country to launch a national remote monitoring program, where every single person that had COVID and was deemed to be clinically vulnerable was sent an oximeter. So that's a little device that you put on your thumb that measures your blood saturation. Now that device reading would then be inputted onto an app, where you as the patient would pop that reading in, and your clinician, whoever's overseeing you, would be able to see, oh, okay, Isa's blood pressure is dropping, or his blood saturation is too high. We need to call him in for a review, or he's deteriorating very rapidly. Rather than someone ending up in hospital, because by that point it's too late. So how do you pick these things up earlier? And when I was doing this work, I realized two things, and to answer your second question, one fundamental challenge in the way even the NHS, the National Health Service, was thinking about this very problem was largely excluding older people, where they were thinking, oh, well, we're looking at the masses, we're going to roll this technology out and focus on the main population, which is at risk. But actually, a lot of people that were in hospitals, a lot of people that were suffering, that were vulnerable, were older people. And so if we design an entire technology-enabled pathway that was so difficult for an older person to access and use, then we failed them. And so that was one big challenge. I think that has slowly been addressed, but not fully. And then the second thing I realized was we had all of these weird and wonderful apps that had propped up over the pandemic and before as well. And every single one of them was looking at a healthcare journey or a care journey. And medicines is the most common intervention in healthcare. In every single condition, in every single pathway, in every single care setting, people take medications, and they take a lot of them, far too many to be frank. And all of these apps, you could integrate all kinds of weird and wonderful Bluetooth-enabled devices, smart blood pressure monitors, smart weighing scales. You could track biomarkers, which I still don't even know what they are. But weirdly, the medicines piece was kind of up to you to figure it out for yourself. So you could be someone in your own home with limited support, inputting your blood pressure readings, and your blood pressure might be spiking, but you don't actually know that's because of the medications you're taking or not taking. And your carers and clinicians also don't know that, because all they're seeing is, oh, the blood pressure reading is going up and down, wonder what's going on. So there's a real disjoint in the way in which the world of health and care had evolved and has been evolving recently and continues to evolve without looking at that medicines piece and without looking at older people. And I think bringing those two things together is because they viewed it as far too complex. The juice wasn't worth the squeeze for a lot of these providers, because they're focusing on the mass market where they can easily attract customers and they can just get them latched onto these apps and continuously using them. So we kind of said at Connect Care, why don't we focus on that very problem and let's not shy away from it.
Wow, fantastic.
So yes, how are you today?
I knew it was the right place to be here today. Now, I suppose another question for you is that there is an increasing expectation that we as users should have control, I suppose, over our own healthcare journeys. How have you been able to create the expectation that this should include adherence to meds and meds management, and when actually medicine seems to be perhaps the least exciting part of the journey? Yeah,
no, it's a really good question. I think it's a big challenge, and probably why a lot of platforms and companies haven't focused on this one issue. And I think fundamentally it's probably even the way we think about medicines. So I think you used the term adherence, which came from me, but historically the term adherence, this is how NICE, the National Institute of Clinical Excellence, defines adherence: the extent to which the patient's action matches the agreed recommendation. And it's such a paternalistic term, right? It's such a term that denotes that we, the doctor, who sit higher up than you, have prescribed to you, the patient, this medication, and you need to take it. And if you're not taking it, you're non-compliant, that's what they used to call it before, or you're not adherent to this medication, and we're going to call you in, we're going to give you a slap on the wrist, and we're going to send you back home with more medications to fix it. And it's such a dirty term for me. I think the way in which we even think about medications need to radically change. And now, so we kind of say we're not in the medication adherence space, we're in what we call the medicines optimization space. And medicines optimization is a new term that's only slowly starting to get traction. And what the NHS refers to it is as the change in the way that patients are supported to get the best possible outcomes from their medicines through the adoption of a patient-focused approach to medicines use. And what that's about is actually saying, first, before you even say, are you taking this medication, is this medication even working for you? Yes. Do you even want to take this medication? Is there a reason why you're not engaging with your medication? Because often when people stop taking their medication, it's not because they just don't want to. It's either it's not working for them, the belief system isn't right, they don't have the right information and tools to actually independently manage and take those medications. And that's the way we've approached this problem of medication management. Actually, let's focus on this. And what that fundamentally means is you have to give people the confidence. You have to give them confidence in their medication regime, so they actually understand it and are willing to take ownership over it in the way they do with their wider health and care. And that's really crucial to even our business mission, is we're here to give people the confidence to make the most of their medicines. And that's everything from managing them, to understanding them, to engaging with them. And the second building block of our service and what we're designing in Oxfordshire is sustainable routines, helping people develop a sustainable routine around their medications. which is embedded in their day-to-day life. It doesn't require them to go and do something completely different and alien to them, or record their readings on some kind of app, or have to manually log what they're doing. It sits within their day-to-day processes, because medicines is also one of those things where, whilst it is the most common intervention in healthcare, it has sadly, for a lot of people, become the be-all and end-all of their healthcare journeys. It's the very thing keeping people in hospitals. It's the very thing keeping our loved ones in care homes when actually they want to be in their own homes. And it's the very reason we're sending out carers en masse, which we can't afford to do as a country anymore, just to nag people and remind them, prompt and take their medications. So if we can help people develop sustainable routines around their medication, we don't need all of that. And lastly, is offering that support and that reassurance when things aren't right. When we notice that the safety net, when something is going wrong, when something isn't quite right, providing that reassurance and that safety net, because ultimately we do have to safeguard a lot of these people who are at risk and often are vulnerable. And we've got this logo on the right-hand side which shows the NHS and care together in kind of a feedback loop in an endless world, because historically this world was very siloed. It was the NHS saw their responsibility as prescribing drugs and looking after people in hospitals. Social care saw their responsibility of helping people in their own homes with their medication, but those two worlds weren't working together. And when we think about medicines in an optimization way, we kind of do away with those institutional boundaries and think of this as one uniform system, which I'm sure Didi will be able to talk about as well.
Oh, that's wonderful. So yeah, fantastic segue into the question that I want to ask Didi. So in your role as Health and Care Innovation Lead at Oxfordshire County Council, and also your experience in public care, adult social care and commissioning, so you've had amazing insight in so many different areas. You must actually really truly understand the value of collaboration. And I suppose when it comes to this particular project, what attracted you about first of all, you getting involved with it, and how all the other organisations started to become part of it, a much bigger, wonderful collaboration?
So yeah, you're right. I'm passionate about collaboration. I'm also passionate about independence for older people. And before I go off on a tangent, I just want to, I will answer your question, but I wanted to talk a little bit about technology and social care and the cultural kind of implications around that. It's the elephant in the room. Most people in social care, for better or for worse, do not believe that using technology is caring. I'm being a little careful about how I say it. Care, when we care about people, it has got to be a face-to-face interaction. And while I believe that, I'm also very passionate about people's independence, people being able to use technology and preserving capacity in the system so that human hands can do the tasks that only human hands can do, and technology can do the other stuff, if that makes sense. Yeah. So I think sometimes in social care there is that cultural battle, and what I've found with this project is that collaboration, where sometimes when I'm pushing a new innovative idea that's technology based in social care, I can get a lot of pushback for the reasons that I've just talked about. With this particular project, it's like an idea whose moment has absolutely arrived. I was astounded as an innovator how on board I was getting everybody around the system. And I think there's a couple of reasons for that. I think we all want to do the right thing for older people. That are in our care, both in the NHS and in social care. But there's a pressing problem that if anybody's watching the news at the moment, they will understand that there are plenty of people sitting in hospital at the moment that are fit and medically well to be discharged, and they can't be discharged because there isn't a social care package ready to pick them up. And that isn't unique to Oxfordshire. This is a completely national problem. So it's not great for the person who's sitting in hospital. It's not great for people that need to get into hospital because the beds aren't available, and it's not great for the sector as a whole, the pressure that's being put on us. So I think collaboration in that sense was easy to foster because it's it's just one of those magical moments where we've got the tech, we've got a fantastic team, and we've got the manpower to put behind it to really commit to service design. So this isn't, it is true collaboration. It's not myself at Oxfordshire County Council and ESA as a technology provider telling everybody what they need to do. We spent really committed time working with our partners around the system, so all of them in health, in pharmacy, in social care, and getting everybody's feedback as to what this service should look like as well, and also users of the service. So I can't stand the term, patient and service. I can't bear it. So people that are going to be using this technology, what their views are as well. And that's also allowed us to really future-proof this project. So it's been my experience as an innovator as well that we like to run along and have a fantastic idea without any really forethought to what that's going to look like in the future. So we've gotten everybody's input so that when we're ready to scale, we can.
No, that's wonderful, and I think it's brilliant that you are actually starting to think about the future, because I think you're right. It's sort of, sometimes it's just doing the first step, but often I think sometimes with innovation, especially when it's tech-driven, it almost focuses on like the art of the possible rather than the actually understanding that actually real people have got to sort of find a way of feeling comfortable for this. I mean, I think, as you said, that, carers don't think that actually technology maybe is a good form of caring. It's like a human kind of thing. So I suppose I'm interested is how are you encouraging people to engage with this, with the technology, and to feel that it's right for them? And I suppose, and how, with the program, the Connect program, I suppose this question for you, Isa, is how can we make it inclusive so that it doesn't alienate people through the technology?
No, it's a really good question, and I think to your question, how do you get people to engage with the technology? If you're having to ask that question, you've designed a service that doesn't work. And fundamentally, it's because historically they used to say there's a pill for every ill. In the BNF, which is the national formulary of all the drugs that are licensed in this country, there are 18,000 medications licensed. In 1960, there were about 1,700. Right? That's the increase in number of medications that we are prescribing to people now. And the typical patient that's on our service is, for example, 8 is minimum usually of number of medications. We've seen up to 25 medications a day. And now, though, what we're seeing in healthcare and the transformation of health and care, there's an app for every ailment. There are 350,000 health apps that exist on the App Store focused on healthcare. These are everything from hair loss for men to women's health issues, to fertility care, to managing diabetes, to managing, you name it. There's an app for everything. Think of a symptom, think of a condition, think of a care setting, there's an app for it. And there are probably hundreds of apps just doing that same thing. And every single one of these apps requires heavily on patients to tell you everything, them to constantly engage with you, give you data, tell you information about their about their condition, for example. And so they're not very inclusive by their very design, because they rely so heavily on typically someone who's vulnerable and needs support to be telling you everything that they need support with. And I wouldn't be surprised in the next few years, obviously with the way the market's going economically, these apps come crashing and burning. And so we kind of what we would always do with medicines, and going back to my point earlier, medicines not being the be-all and end-all of someone's healthcare journey, is that we should sit at the back end. We say as a company, we're happy to be invisible. The patient might never even know who Connect Care is, because everything we do and we deliver through existing systems, existing technologies, existing tools that people are already using and know how to use and are inclusive. So to give you an example of those 3 things, confidence in regimen, how do we help people develop confidence? When someone joins our service, we provide their carer or their care provider, whoever is supporting them, a framework through which they can have a conversation with that person as a person to understand their needs, understand their concerns, really form a picture of that person and understand what is their normal sense of self. That can just be a paper and pen exercise or just on the drawing board, just to really have a conversation with that person. Pick that piece of information up, send it back to us as Connect Care. We then, for sustainable routine, that's really where the technology part comes in. We have a smart medication box which can be used by any patient with any kind of medication needs. And it's a very simple smart box. It's a simple piece of cardboard where if you were to look at it, you'd say, this is the technology. But it works because what it is a simple cardboard box that you can put all of your medications in. If you have glasses that you wear when you take your medication, you can pop those in there too. If you have a little leaflet that you put in or sticky notes, you can put those in there as well. When it's time to take the medication based on that person's prescription schedule that we hold on them, a little pager will remind and beep to remind them to take their medications. And they can change that. If they say, for me, morning is not 9 a.m., for me, morning is 8 a.m. or 10 a.m., they can change that to that reminder, to that time. And importantly, when they open that medication box has little sensors that the person never even sees or knows about that's detecting whether they've opened their medication box or not. And that information is fed back into our platform. So we can know Mrs. Jones, who's living by herself and has told us that 9 a.m. is the time she'd like to be reminded for her medication. She hasn't opened her box today. What do we do now? And so we kind of form a picture of that person and what their normal sense of self is. But instead of escalating that straight away to a responder or an emergency responder to come out and say, Mrs. Jones, you haven't taken your medication, what's going on? We said, no, let's not do that, because then we're just replicating what the current model of care is, which is completely broken. Instead, let's form a picture of Mrs. Jones. And if we notice that Mrs. Jones' schedule is dropping day by day, that's when we step in. That's when we tell their care provider, why don't you go and have a conversation with Mrs. Jones, find out what's going on. And you might find out that Mrs. Jones said, well, I didn't open my medication box because I just didn't feel like it today. And that's fine. At least we know that now. And so that's kind of where the sustainable routine element comes in. And then the final piece is that support when things aren't right. And what we can also do is send digital check-ins with Mrs. Jones. So if we've noticed that Mrs. Jones' routine seems to be getting worse, and we also know from the data we hold that Mrs. Jones is a new prescription medication, so maybe there's something going on here that we need to check in with Mrs. Jones about. So we can just send Mrs. Jones a very simple form to fill in. And if Mrs. Jones doesn't know how to use the internet, we can do that on an automated phone call as well, or a call centre can call her up if they need to. Or the care provider, when they go in next time, can have that conversation with Mrs. Jones. Pick up with Mrs. Jones, what's going on? Why are you not taking medications? Is there something concerning you? Mrs. Jones might say, since I've been taking this new medication, I just feel I can't leave my bed and I don't want to take it. And at least they know that information, they can then take that back to their doctor and take that and empower them to also make the decision. So actually, rather than Mrs. Jones relying on the carer to tell that information, Mrs. Jones can go directly to her GP and say, look, Mr. or Mrs. or Miss or whoever is the doctor, I'm not taking this medication and this is the reason I'm not taking it. And at least empower them to then make those decisions around their medications.
I think it's one of the things I really love about this project is that it is technologically based, but the technology is hidden. And also there is a flexibility of choice to the user, and I think that it's a rarity. So I mean, I really do applaud
Can I just
you.
jump in from a local authority perspective as well? There's a couple of things, and I really like the way that Isa has described kind of giving that independence to people. But classically, what we've done in local authority is when and it's the right thing to do, by the way. It's the right thing to do for the system, and it's the right thing to do for the dignity of that person. But classically, what we've done as a system when people don't take their meds, if they're using a Pivotal or whatever, is, at cost, we send somebody out almost in a paternalistic way. It's a warden will come out and at cost to the system, by the way, and kind of tell them in a teacherly way that they need to be taking their medication. And if they're not doing it in the first place, it's just reinforcing the doing to them, which is what we want to get away from.
Well, exactly, and I think this sense of empowerment that that I'm in control, I think is wonderful. Now, I suppose it goes back to a question for you, Didi. I know that Sally might have answered this if she was here, but as you say, there's a lot of people who are stuck in hospitals, and I think one of the reasons why they are is they're sort of like the medicine pathway. How can the collaboration with Connect, how can that help people get out of hospital?
So it's about doing things differently. So everything that we've been talking about is just common sense and dignity for people, but it's about doing things differently at a really opportune moment in time as well. It's been my experience that when people start a package of social care, they will continue as they start, right? So it's quite difficult to reduce a care package. And that's not necessarily for people that are leaving hospital. That's for anybody that's starting a new package of social care, because they become quite reliant upon it. But I think at the moment that people are leaving hospital, there's a really opportune moment there to allow them to be independent. And you can capitalize on that moment. And it may not be the same for everybody, but there are many people that are sitting in hospital today that the reason that they cannot leave is because of perceived risk. They will be waiting for a social care package that will have meds attached to it, and it will either be a meds assist or a meds prompt. And if we can work collaboratively with people in that situation to understand their medication regime, to provide them with the kit that they're comfortable with so that they can independently manage their own medicines in the home environment with, as Isa's saying, a safety net that allows us to know when things aren't necessarily going perfectly and to give them that support. They will not build that reliance upon a social care package that wasn't necessary in the first place.
Yes,
and again, I need to just kind of say, I'm not wanting to give people social care packages. I think we need to make sure that people that really need them for things that only carers can do, we need to make sure that that capacity is there. So it's the right thing to do for people leaving hospital, and it's also the right thing for the system.
No, absolutely. Yeah, sorry, darling.
I was going to just to build on that. I think that you and I know this from the challenge. The challenge is that all of this kind of innovation, it's difficult. It's not easy. It's not something that's going to overnight just happen. And crucially, it requires us to develop completely new models of care that just do not exist today. Because where you, as Didi said, if someone has a social care need for meds, that means we send out carers to do meds assist or meds prompt. What we're not willing to do, or systems right now are not willing to do, is think, well, how about if we give someone these technologies for 12 months and we just have light touch support, then we don't need these care packages. We say, oh, we're not allowed to commission that, or we don't commission that. That's not the way our commission works.
It's not the way we do it.
It's not the way we do things. So they're very happy. What you'll find, and what we find as technology providers, is that integrate systems, both NHS and social care, are very happy to pilot stuff. And they see the savings, they'll themselves champion it. And then when it actually comes to commissioning these things, oh, but we don't have the commissioning funding structures in place to do this. And so what that means, and that's why I think a lot of these providers and platforms have gone for the direct-to-consumer market, is because if you want to build a business in this space, you then have to do that, because you have to go after the worried well who can pay for it themselves.
Yeah. Okay, so I've got a question for you. So what would you say to two groups? One, to innovators in the space who are trying to get people out of hospital into their homes and allow them to be empowered and independent. So that's one question. But actually, what also would you say to the commissioners?
Ooh.
Which one do you want to do?
What would I say? I'll reiterate that I think this particular idea, it's an idea whose moment has come. So for me as an innovator, I am a person who is known within my local authority of constantly putting my head above the parapet and kind of bringing new ideas. I think when you are piloting a new idea, it is much easier to do it if it's answering a defined need.
Yeah.
I think people are much more willing to collaborate and take the risk and work together when there's real potential to solve problems.
Right, okay.
So I think it's choose your theme wisely.
Okay.
Which we have done in this case.
And do you agree?
I definitely agree with all of that. I would say to innovators is, which actually, yesterday Didi and I were at the House of Lords on a panel in similar themes, and one of the panelists said in front of their Minister for Innovation, don't build your business model around the NHS. And I think that's definitely true, because if you build a technology-enabled business around the NHS, hoping that the NHS will one day put their hands out their pockets and pay for it, you're misguided. Because the reality is, and this is a sad reality, the NHS is slow. The NHS is slow at changing. There's a huge cultural mindset shift that needs to happen, and they are just not willing to make that right now. And so if you build an entire business model that is only reliant on the NHS buying it, it becomes very tricky to actually do the good things. It actually becomes very tricky to develop something that works. And it's very rare to find partners like Oxford County Council and like Didi who are very forward thinking. And I always joke to Didi that she's quite refreshing in the world that she's in, and because and I think culturally there's been a mindset where in social care, for example, when we think of technology, we thought about telecare. These are providers that were giving equipment to people, and a lot of them are ripping social care providers off. So it's no surprise that there's a lack of confidence in technology in this sector. But we kind of can't wait. We as innovators, and to anyone innovating in this space, is don't wait for that change to happen. You will have to drive that change.
Yeah, you have to
and
be
it
the
is
change.
grueling and it is tiring, but you have to keep going, because one day, I hope the NHS and social care will be ready to innovate at scale, and you've got to be there waiting for that to happen.
No, I think you're right. I think any kind of innovation in this space requires patience, but also this a strong team to sort of because it is arduous at times, isn't it? So, a theme which is very strong around design for healthy aging is designing with the users. Now, obviously, you've talked about the strong ecosystem who's involved. So I believe you're going to share some insights about one of the users that you've been speaking to hear their views on the whole process. Yes?
Yeah, definitely. So it won't be a user in Oxfordshire, because that project is going live in January. We actually have Elaine right at the back, who's one of our design researchers and user researchers, been working really closely with our user groups. But the example I'm going to share with you is from our work in Lancashire. So we work hand in hand very closely with Lancashire County Council and the new integrated care board that's been created there. And this is, sadly the patient wasn't comfortable doing a video, so I just kind of presented at a high level the journey of the patients. Mrs. C, for anonymity, I can never get that word right. She's 81, lives in Lancashire in a very rural area. Mrs. Jones' medical history, so she was managing frailty and has been for quite some time. She had type 1 diabetes with sight impairment caused by her diabetes, and she is at risk of what's called polypharmacy, taking multiple medications. Mrs. Jones is taking 14 medications a day with an incredibly complex regime where some are supposed to be taken on some days of the week, some are supposed to be taken at different times. Very complex to manage for her. Mrs. Jones was on what's called reablement. So when she was discharged from hospital, she was discharged into what's called at-home reablement, where for a 6-week period, social care providers come in to support Mrs. C with everything, her wider health and care, helping her make a tea, helping her regain her confidence as she goes back into the world. And Mrs. C has also had a prior admission into crisis care, so she's quite a vulnerable patient or person. And actually, when the reablement worker was coming in to provide support with meds during her reablement period, she said to the person, I think in very true Lancashire fashion, in Lancashire we're all very direct, said, "Get off, it's my tray." And she refused to allow the carer to administer the medications for her, which I think speaks a lot, right? Because it shows that she wanted to be independent with her medication. She doesn't want someone else coming in, taking the pills out of her blister pack and giving them to her. And today, after being on our programme, so the programme we have in Lancashire is similar. It's a slightly more reactive model than the Oxfordshire one. After 3 weeks, Mrs. C had a completely sustainable routine, completely independently, with no carer supporting her with her medication. And to my point earlier, she wished to stay on the technology enable pathway, but guess what? There was no funding model in place to support it. Social care were willing to pay for carers to come in 4 times a day to remind and prompt Mrs. C with her medications, but they were not willing to pay for a technology that would cost them per month what it costs 1 care visit. And that's the world we live in today, sadly. And to hear from Mrs. C's own words, she said, it's been I've not made this up, by the way, this is completely true. It's been and actually when Rachel, who leads on our service delivery, sent this to me, I said, did you make this up, Rachel? Because this is my talk. She said, it's been marvelous. I was so stressed out about my meds before. I like watching the lights and knowing it's the right time. It's allowed me to focus on managing my diabetes and not worry about my medicines. I think that quote sums up everything we've been talking about here today, where she was someone who's stressed out about their medications, something that shouldn't be the be-all and end-all of their life had become the be-all and end-all of their life. By the way, Mrs. C also lives with her husband, who is even more vulnerable than she is. And so the fact that she had to stress about her own medication is already a problem, and then her husband as well. She likes watching the lights and knowing it's the right time. Something that was so boring to someone before and so dignity stripping was now exciting. It was something interesting for her to get involved with her medications. And crucially, it's allowed her to focus on her diabetes, the one thing that does define her life, the one thing that she can be in control of. She could actually spend time thinking and worrying about that rather than just, has she taken her medications today? And I think with that I will conclude.
Well, I have to say that is a rather fabulous quote to end. Thank you. What an absolutely extraordinary session. And I think, for me, it's about sort of like the technology is hidden, and actually what you're seeing from as that last comment is a sense of empowerment, but also actually a sense of delight. Now, isn't that incredible? Who would have thought that taking medicines would allow that? So, ladies and gentlemen, this is an opportunity for you to ask Didi and Issa some questions. I've got a couple here which have come on Slido, so if you've got any more, please send them, because I do have a little bit of time. Okay, so a question for I suppose, Issa. I mean, I'm interested as well. Are there any images of the medication box?
I don't know how I can bring them up here, sadly.
Right.
But if you, I don't think it's on the presentation, sadly. Otherwise, we'll be able to show them.
And I'll tell you why, because and I think this is really, really interesting, because a lot of the medical, a lot of the equipment, the offerings which are given to us as we age, are very ugly, very demeaning, very stereotypically grim. And I suppose the question is here, and I think it's a really good question, is the design process of creating the box. Can you talk a little bit about it? Because actually having this box in our house, for it to look nice as well, so it can sit within our environment. Can you just talk a little bit through that design process?
Yeah, so what's crucial as a company is we don't manufacture devices. We're not a device manufacturing company. What we do is we scout out in the market what exists when it comes to inclusive technologies and hardware that's already out there that can be used for a medication purpose. So one suite of offerings we have is what's called a medication cabinet sensor, which you don't even see. All that is it's like a fridge magnet. When you open your medication cabinet, so you can just stick it onto your medication cabinet, that will detect using internet-enabled technology, basically, that you've opened your medication cabinet. So that one you don't even see, so you can just put it on top of your existing cabinet. The other one, which is the box we're referring to in Oxfordshire, that's basically a simple cardboard box that can be designed in terms of the look and feel however you like. And crucially, as I said, it's a very easy, you can do whatever you want with it. We're even testing one thing which we could do is where if the patient wants to have a little stick on their notes about their medication, if they take notes about them, they can just stick it on there. And there's a little simple pager that just says, it's time to take your medications, and you can surface personalized information on there as well. So it's very simple. I mean, if you look at it, you think, wow, there's just a simple cardboard box. But that's the beauty of it. And then the one in Lancashire, that's a smart pill box. So it's designed for people that are using medication trays, and it basically has flashing lights in it. But I don't know what the best way to, show it. If anyone wants to drop me out, catch me after this.
What I would add to that as well, as when we met with stakeholder groups, so it was a lot of health colleagues from the Home First Reablement team, and we were showing them the box in Oxfordshire. What they came out with, they couldn't believe how simple it was, but also the ability for a person using that box to be able to personalize it in the way that they wanted. They can stick pictures all over it, or stickers, or anything that they want. It's just a box.
I mean, that is truly wonderful, actually. Yeah, I mean, I think that...
and it doesn't require Wi-Fi or broadband.
Oh my God, it just gets better.
It
makes me want to have one.
Which is when you think about rural communities, which with my commissioning hat on, I would say is a big barrier to people being able to use technology-enabled care in rural areas of the county where they may not have equity of broadband coverage. It's a perfect solution.
Absolutely, wow. I mean, you have really thought about everything.
Well, we had to go all the way to Israel to get it.
Okay, okay. Well, that sounds like a very, very good trip to do. So a question has come around, I suppose it's from an inclusive perspective and sustainability. And this is from Fiona Willis. When you looked at the sustainable route, did you address how this could be delivered to people with cognitive decline?
Yeah, it's a good question. I think the challenge we've had with patients whose cognitive abilities have declined to some extent is often they will need in-person support, and they will need carers supporting with not the actual reminding and prompting, but sometimes even with the administration, they often lack the manual dexterity to administer their own medication. So it's always been quite challenging to support people with very high needs. And we're actually very clear about that when someone comes into our pathway, we do a robust eligibility check against things like manual dexterity, cognitive abilities. What we can do is pick people up before the cognitive decline starts and support them in remaining independent and preventing that, because a lot of times what happens is people who don't have the ability to do little things with their medications, they'll be put into a full-time institutional facility, and that's where you see a rapid decline in their cognitive ability. And it's really picking those people up before we get to that stage. Sadly, right now, once they are at a level where they can't manage their own medications, there's not much we can do for them, which is a real shame. But I think that's why, to Didi's point, you have to free up you have to use technology to free up hands to do what only hands can do, and some people might need that in-person support.
No, thank you. Do you anything you want to add?
I just wanted to add, thinking about cognitive ability, it's why it's really important, as Isa was saying, catching people at that right moment in their journey. And I'm really, really conscious that the service model and pathway that we are working on in Oxfordshire, it's such an opportune moment when people are leaving hospital to set them on the right path. And I always like to say, with anything, like whether it's with people using services or dealing with providers, you've got to start out as you mean to continue, So if you want people to be able to independently manage their medicines, you need to give them that opportunity to do it when they're leaving hospital.
Yeah.
And you're setting them up right for, even if they're going to maintain their independence, or even if they're on a long-term care package for other things. I think it's important for people to be able to maintain that independence and dignity around medicines.
No, absolutely. And I think also what's really exciting about it is the fact that at that point you can personalise it. You can see that there is some kind of like delight in it. It's not another thing that I've got to worry about. So no,
it might even surprise you to know that not everybody wants carers to come into their house 4 times a day to tell them to take their medication. I mean, it's.
So there's a question here from Trudy Fallon, I think it's for you, Isa. For someone receiving home care, their provider will be recording meds too, but along with care plans and visit notes, etc. How does this work for care providers?
Yeah, it's a good question, and that's why, to the point earlier, we're happy to be invisible. We actually work with certain care planning systems that are used by these care providers so they can integrate this information into their technologies. So if someone, for example, let's say is being supported by a domiciliary or a home care provider with 1 or 2 care visits a week around their medications, the times that they're not there is what we focus on, and we work with those care providers to do that. So all the work we do in Oxfordshire, in Lancashire, in other regions, it's always with the care providers. Now, the challenge often is that, from a care provider perspective, if they can bill and charge for 4 care visits a day, from them the financial incentive is to carry on doing that. And so it does require a bit of, I guess, forward thinking from these care providers as well, and not really, this is not a threat to them. Actually, what it does is it frees up capacity for them to actually use their carers on those that need it the most. And because meds only visits, rather interestingly, are not profitable for care providers. So for them to send out a carer 4 times a day, the travel time associated is so high that they can only bill, the maximum they can bill is half an hour. And actually that's a visit that might take 45 minutes. Yes. Whereas if they can use that time for a combined care visit to do other things, and they just don't have enough carers to do that anymore anyway. So actually care providers are no longer seen this as a threat as they historically did. So we work very closely with them and their care planning systems as well.
Yeah, no, fantastic. So this is a question from me, sorry, very selfish. I'm very interested in the whole design process, because often we start off with an idea, and then by collaborating and listening and exploring and trying things out, we suddenly find ourselves into a very, very different place. I'm really interested, what was the most surprising moment from this process, and how did it pivot you from one process, one part of the project to the next?
Me or you?
Why don't you go first?
Wow. Well, I mean, we spent a lot of time speaking to all of our stakeholders and partners in Oxfordshire. So I think the thing is, when you're piloting innovation, I mean, piloting innovation is piloting innovation, right? Otherwise, it would just be contracting. If things were going to change, we would just stick to the course that we had intended and what we thought it was going to look like. So, I think initially what we had envisioned much more was a Dosset box rather than a meds cabinet. And we absolutely took on board, because everybody loved this kind of smart Dosset box, we took on board feedback from from frontline carers and occupational therapists and community nurses that, well, this is fantastic for pills. What about if their medication regime changes, which it does when they're leaving hospital? What about people who are using creams and inhalers? How you facilitate that? And so we took on board that feedback. That's just an example. There are many other, but that's the biggest one for me. We took on board, and so we adapted the technology or the format that we were proposing to use in the first instance. Now, if we were contracting, we would have gone ahead and ordered 1 million Zippy smart boxes, and then we would have had a self-fulfilling prophecy that technology doesn't work in social care.
Absolutely. Yes, exactly. So, thank you for sharing that. I mean, that's why I go out and talk to people and listen to them. You said, what was the most surprising moment for you?
I think for me, and it's probably thanks to Elaine and Magda, it was the way in which we reframed our entire thinking around what we were doing. The work we were doing in Lancashire, that was a smart pill box, and that basically the sell to local authorities was, you're sending carers out 4 times a day, our technology does that for you, so you can replace carers one-to-one with this, where instead of carers nagging your service users, we will nag your service users using this technology. And now, when we've reframed it and the pathways we've chosen in Oxfordshire, it's more about supporting that person to become independent with their medication. And it requires a completely different model in the way in which you can think about the technology itself and how the technology is used, because it's the same technology, it's the same data coming out of it, but it's the way in which you frame that information and how you use it and embed it has completely shifted. And that for us has also opened up loads of new opportunities and loads of new doors, because this could mean that theoretically with that new model, we could offer this on a direct-to-patient or direct-to-person level as well, where it doesn't have to be through social care, it doesn't have to be through local authorities, because this could be anyone that's discharged from hospital that has the means to pay for it could have this instead of paying for carers if they're paying for it themselves.
No, absolutely. Well, I have to say, as someone who was going to come and listen and actually had the joy to actually sit here and talk to you directly, I think this is just the most extraordinary example of collaboration, a big vision, seeing technology not necessarily as a driver, as a support, but more importantly, the joy of working together and user-centered design. And I think, the potential for giving people joy, empowerment, and the personalization is absolutely extraordinary. So you guys are going to be here if people want to ask you questions and to have a look at the boxes. But I just want to say, wow, I can't wait to see the next stages. And I think I would like all of you to put your hands together and say thank you to Didi and Isa. Thank you.